I'd like to thank APOA for allowing me to give my talk on risk factors for indirect decompression failure after OLIF surgery. So as we know, OLIF has seen wider use recently due to its ability to restore disc height and to indirectly decompress the neural elements. Cases with poor postoperative radiological outcomes and inadequate symptom relief can occur and ultimately require reoperations through a direct decompression surgery. So our aims is to investigate if implant-related factors such as cage size and cage position are associated with radiologic improvement after OLIF, and to investigate the risk factors associated with revision posterior decompression surgery after OLIF surgery. So across 4 years, we have included 92 consecutive patients with 188 levels with lumbar spinal stenosis. They all underwent indirect decompression via OLIF surgery with or without posterior instrumentation. We also assessed whether there was an indirect decompression failure as defined by revision surgeries within 6 months or persistent compression symptoms after 6 months after surgery. So these are some measurements we made. We assessed on the axial T2 weighted image, the durosac cross-section area, the ligamentum flavum area, the left and right subarticular diameter, and the left and right ligamentum flavum thickness, because what we're trying to look for is whether indirect decompression will increase the size of this canal while also reducing the thickness and also the width of the ligamentum flavum, as well as the subarticular diameter. We also looked at, on the x-rays, the position of the cage, assessed by whether it is at the center or anterior or posterior place, and the amount of anterior and posterior displacement from the center position as measured. So we found that anterior place cages are generally associated with larger postoperative segmental lordosis. You can see here 14.6/10, and better segmental lordosis correction of 1.2 degrees versus negative 0.1 as compared to posterior cages. So for surgical levels with a more posterior cage position, we found, however, that the indirect decompression is probably more significant with a higher postoperative posterior disc height and a larger right subarticular diameter improvement, as well as better reduction of the ligamentum flavum thickness. 12 of our patients did have indirect decompression failure, which required a reoperation surgery. And based on this, we ran a multivariate logistic regression that after adjusting for age, sex, and BMI, we found that small preoperative durosac cross-section area, as well as anterior position cages, were independent risk factors for indirect decompression failure. That means that we expect a smaller canal size. We probably want to place a more posterior cage to get it jacked up much larger. And if the anterior cage is positioned, then we probably don't get as much indirect decompression. And we ran an ROC curve, which found that a preoperative durosac cross-section area of less than 44 millimeters squared may not be suitable for indirect decompression. So in conclusion, we found that based on early postoperative radiological results and improvement of VAS scores at 1 year follow-up, we found that OLIF is an effective procedure for indirect decompression. For the spinal alignment correction, generally you want to get it more anteriorly cage placed, but if posterior cage is probably better for indirect decompression with increase of the central canal space as well as subarticular space as well. Surgical levels with preoperative durosac cross-section area of less than 44 millimeters squared probably are not suitable for indirect decompression. Thank you.